We'll now bring up Vitale Cilli, talk about the long-term assessment of collagenase treatment for Dupuytren's contracture, a 10-year follow-up study out of Rome, Italy.
Good afternoon to everybody. Our disclosure, so none of the authors had any conflict of interest. So enzymatic fasciotomy with collagenase, it was a game changer of the treatment of Dupuytren disease. But despite the benefits, the long-term outcomes remain still unclear. And this is why there is a growing trend of reassessing the patient who underwent this treatment. In our aim was to compare the result at the short term, 12 weeks, and long term, 10 years of our patient that underwent collagenase injection. We enrolled 45 patients with palpable cord at the MCP joint or PIP joint. The passive extension deficit had to be at least 20 degrees in the MCP joint. The combined passive extension deficit had to be at least 45 degrees. That makes all the patient in Tubiana state 2. The deformity, the lack of extension of the PIP joint was allowed to be at any degree. The table test had to be positive, and the cord should be palpable. Had to be palpable. Breastfeeding patients were excluded. Patients who underwent treatments at the same end less than 90 days before were also excluded. And so as a non-compliant patient or patient with well-known hypersensibility to collagen. The treatment consists in injection of collagenase followed the day after by forced extension and splinting. The splinting lasted 2 weeks, 1 week 24/7, and 1 week 12 hours per day. The evaluations were made at 12 weeks, 7 years, and 10 years post-treatment. The primary endpoint was the assessment of the efficacy and the occurrence of relapses after 10 years of follow-up. The function after 7 years was the secondary outcome. How we did measure the outcome? By measuring the passive extension deficit, total passive extension deficit, and with the VAS scale, Michigan, and Durham scores. The results about the MCP joint are related to 31 patients treated. After a follow-up of 10 years, we had a passive extension deficit of 11 degrees in media. Total passive of 25.8, a recurrency rate of 29%. The satisfaction score with the VAS score was 6.7, and the standardized Michigan and Durham score were respectively 80 and 59. About the PIP joint, 6 patients treated, 100% of recurrence at 10 years. The passive extension deficit was 41 degrees, and the total passive was 56 degrees. Satisfaction was less here, instead of 6 is 5 on 10. The standardized Michigan is 70, and the standardized Uram 63. The injection of Clostridium provide better outcomes in our experience for MCP joint than in PIP joints. The recurrence rate is likely due to the pathophysiology of the Dupuytren disease and due to the nature of the treatment, as this treatment does not eliminate portion of pathological aponeurosis, allowing the pathological collagen stay in the hand and provide the relapse. Patients are generally satisfied with the treatment, especially when the treatment is applied to the metacarpophalangeal joint. We would still recommend this treatment, yes, but especially for the MCP joint, very less for the PIP joint. But we would insist with the patient about the risk of recurrence. In conclusion, the injection of Clostridium is effective and recommended, especially for the MCP joint and for the PIP joint. It should be avoided, in our opinion, in PIP joint because the durability and the satisfaction are poorer. Reintervention is an option that takes place very often. And most important, the patient, as always, should be informed about the risks and the recurrence related to the treatment and to the pathology. Thank you for your attention.
Thank you very much, Vitale. One quick question. Of the 100% of patients who had PIP joints and recurred, how many of those patients actually requested repeat treatment?
All the patients request for treatment because at the time, all the patients included had to sign an informed consent, an informed form, and only the patient who requested after the discussion with them.
Thank you. Any questions?
Where did you infiltrate your PIP joints?
So the infiltration was made into the cord. So we used to add the cord between the two hands and injection at the MCP. So especially where the cord was seen, where the most tension of the cord was seen.
I think we could improve the results using ultrasound because
but,
you see what you are doing.
I agree, but you have to take into account that those injections were made in 2012. So it's
another potential improvement today.
Yeah, I agree. This is
the cord rather than just at the base of the cord, or at least approximately, and then maybe a small amount distally. But great results with the MP joint. It's fantastic. Thank you. Any other questions? Thank you very much.